So the next topic we are going to discuss is neuro-ophthalmology visual field defects. Okay, so what is the neuro-ophthalmology? So basically we are going to talk about the nervous pathway of the eye. Okay, so the visual pathway, we have discussed about the visual pathway in our previous lectures also. Okay, so it has two parts, the inner part and the outer part. The inner part comprises of the nasal and the outer part is the temporal part. Okay, now basically we have two eyes as we know. Then these are respectively left eye and the right eye. Okay, so these two eyes have two different fields, and these are named temporal visual field and the nasal visual field. So these are the two fields. It would be in the both the eyes. Okay, the temporal and the nasal visual fields are in the both eyes. Okay, the name itself tells us the nasal visual fields allows us to see in the nasal direction. Okay, and the temporal allows us to see the rest of the vision. Okay, so if this is your nose, so and this is your eyes, so it is divided into two, the nasal one near to the nose, okay, and the temporal one, okay, and the temporal one. So the vision near to the nasal part, this vision which you can see, this vision will be allowed by the nasal visual field. Okay, so this comes under the nasal visual field, and the rest of the part, this is due to temporal visual field. It comes under the temporal visual field. So I hope it is understand to you, very easy student. So respectively in both the eyes this would be the common phenomena. Okay, now talking about the path, so beginning up with the ophthalmic nerve. So first there is the ophthalmic nerve, as you can see. Then comes the ophthalmic chiasma. Okay, then comes the optic tract. Then there is a lateral genicular bodies, and then comes the optic radiation, which ultimately goes to the visual cortex. Okay, we have studied this diagram in our previous lectures also. You can refer to there. So moving on. Similarly, as there was temporal nasal field and nasal visual field, there is something called as temporal fibers and the nasal fibers, but the concept over here changes. Let's see. So this is the best diagram to explain this thing, that the temporal visual field, the image is carried out by the nasal fibers. The temporal visual field is carried out by the nasal fibers, and the nasal visual field is carried out by the temporal fibers. There is a crossing in the temporal visual field and the nasal visual field. So these two different fibers are taking different things. Okay, the temporal one is taken by the nasal and the nasal one is taken by the temporal. Okay, so here comes the concept that if the temporal fibers are affected, then which vision would be affected? The answer goes to the nasal visual would be affected. There would be no nasal view to the person if the temporal fiber, and vice versa. If the nasal fibers are affected, then the temporal visual would be affected. Okay, I hope it is clear to you now. And let's see, why is this concept going on, this cross concept, why it is so? Because light travels in a straight direction. So if the light is coming from here, it will pass in a straight manner. Okay, and it passes to the straight line as a straight line, and it does not bend. Okay, the same concept for the nasal vision. The light is coming in the straight line, straight direction, and that is why there is a crossing, because of the nature of the light. Here it is written, the nasal field coordinate is opposite to the retinal fiber. Why? Because the light travels in a straight line. Okay, it does not bend. Very important point. Okay, students, now what are the examples in which the nasal and the temporal vision can be affected? First example comes is cancer. Cancer destroys the temporal fiber. Obviously student, if the temporal fibers are affected, then the vision would be lost of the nasal. Okay, so the nasal vision would be lost if the temporal fibers are affected. Okay, now the next example comes is pituitary adenoma. If there is a compression of optic chiasma due to any pituitary adenoma, then the vision affected would be temporal vision. Very simple. Let us now see the visual pathway lesions. Okay, so the visual pathway lesions are, the first comes is the lesion in the left optic nerve. There is a lesion in the left optic nerve, and there could be a complete optic nerve lesion. It could be a complete optic nerve lesion, and these could be temporal left fibers are cutted. So if the temporal left fibers are cutted, we all know the vision going to be affected is the nasal vision, and vice versa. Now the visual field of the left eye is absent. The visual field of the left eye is absent in left ipsilateral anopia. So the left eye vision is lost in left ipsilateral anopia. Now here is a concept, students, that since most of the diseases pertaining to the optic nerve, okay, pertaining to the optic nerve are progressive in nature. So the first part of the optic nerve fiber to be affected will be that is macular fiber. That is macular fiber, and this is the most pressure sensitive fiber, okay, or the part. So macular fibers are the most sensitive to pressure, and that is why the first affected part of the optic nerve fiber is macular fiber. Very important point. Now therefore the earliest field loss is the central part. So if someone asks you the earliest field to be lost in an optic nerve injury is a central part, and this leads to left ipsilateral central scotoma. You can clearly see over here that the central part of the left eye has been affected. Okay, so this is the earliest field loss. Now the another type of lesion in which the central optic chiasma is affected, this lesion, okay, so the point of crossing of both the side of nasal fibers are destroyed, and the nasal fiber is destroyed, so the vision affected would be the temporal vision, as we studied. Then if there is a both side temporal vision particularly affected, then this is bitemporal hemianopia, BTHA, bitemporal hemianopia. This bitemporal hemianopia is also called as temporal hemianopia. Okay, temporal heteronymous hemianopia, temporal heteronymous hemianopia, or it could be bitemporal hemianopia. Okay, now what is this hemianopia? The hemianopia is nothing but the both side of the eye cannot see towards the different sides. Okay, now this is a different side. Let's assume this is the left eye and this is the right eye. So this side would be the, so let's assume first going to looking up to the one eye. Let's assume in this eye that this is the left side, this is the right side. Then coming up to this eye, that this is the right side in this eye and this is the left side in this eye. Okay. Okay. So left side, left side and right side. Simple. So the area affected here is left and here the area affected is right, and that is why there are two different sides are affected. Okay, that is why it is called as heteronymous. Okay, hetero means two different. Okay, two different means hetero. So one is left side affected and one is right side affected. Now what are the causes of this BTHA? It could be due to a pituitary adenoma, or and in pituitary adenoma you will see only the upper or the superior, we should say superior temporal part of the vision is being affected. Okay, not the inferior one. The inferior one is normal. Okay, the inferior one is normal. This condition is called as bitemporal superior quadrantopia. Okay, bitemporal superior quadrantopia. Bitemporal as because the temporal vision at the both the side is affected. Okay, superior because the superior aspect have been disturbed. Quadranopia, this word is used for no vision. Okay, so this part affected, it will show no vision. Okay, the next lesion, it is seen due to craniopharyngioma. Okay, in craniopharyngioma, the upper the superior or the upper fibers of the bilateral nasal are affected. Okay, so if the superior fibers are affected, then the vision lost would be inferior one. This is clear. Okay, so the inferior temporal vision would be lost. Very easy. Okay, so here you can see, and this condition would be known as bitemporal inferior quadranopia. Okay, very simple. Now the third lesion comes is the lesion in the junction of the optic nerve and the optic chiasma. Okay, it is also known as the lesion of anterior knee of von Willebrand. Okay, it is also known as the lesion of anterior knee of the von Willebrand. And here the fibers are arranged in a bit complex fashion. Okay, so here is the simplified arrangement of the complex nerve fibers. You can see over here the T is nothing but the temporal fiber. This SN denotes the supranasal fibers, IN denotes the infranasal fibers. Respectively, both the side there is a same situation, else then the right side where the infranasal fiber forms a loop like structure. You can see a green colored loop over here, and that is why this becomes a complex structure. Okay, the same infranasal becomes a loop like structure at the right side also. So the left infranasal and the right infranasal, they give up a loop like structure. Where is the lesion? Which lesion we are going to study? That is over here. This here is going to be the lesion. So the lesion is at the junction of left optic nerve and the optic chiasma. Okay, also known as the anterior knee of the von Willebrand. This lesion. Okay, Now the part affected or the vision affected due to a lesion over here are, so what are the fibers affected due to this lesion? You can clearly see over here that the left side fibers are completely, all of them are affected, and one of the right eye fiber, that is infranasal fiber, due to this loop it is also affected. Very simple. And due to which it is known as the junctional scotoma. Okay, you can clearly see the diagram over here. The complete left fibers are been affected, and the right fibers, the right infranasal fiber is been affected, so the vision affected would be supranasal vision. Very easy. So supranasal would be affected due to infranasal fibers at the right aspect. Very simple. What are the examples or what are the causes in which this type of condition is seen? That is meningioma. The next type of lesion in the lateral part of the optic chiasma you can see, and this is also a bilateral lesion. Always this is a bilateral lesion. Now the bilateral temporal nerve fibers are lost, and if the temporal nerve fibers are lost, the area affected would be the nasal area. Very easy. And this is known as binasal hemianopia. Very easy. Okay, binasal because both the nasal visions are affected. Hemi denotes the same part. Okay, so the same part, nasal part has been affected. And anopia tells us about the no vision due to this affection. Okay, now what are the causes? The causes are hydrocephalus, primary empty sella syndrome. These are the causes. The fifth type of lesion that comes is it affects the left optic tract. It affects the left optic tract. The sixth lesion comes the, it affects the left lateral genicular body. Okay, the genicular body which we studied, it affects the left lateral genicular body. The seventh lesion that comes is the full left optic radiations are being affected. Okay, so respectively according to the diagram the vision would be affected. Let us see. If the optic nerve, if the optic nerve of the right eye is gone, then the right vision would be lost. Very easy. If the left eye is gone, left vision would be lost. If the optic chiasma, the lesion is over here, then the vision lost would be the temporal fiber, so nasal vision would be lost. And there would be a loss of nasal fiber, so temporal vision would be lost in the left eye. Right eye nasal vision, left eye temporal vision. If the optic tract, then also same. Lateral genicular, then also same. Optic radiations are even affected, then also same vision would be affected over here. And even the visual cortex is affected, then also the same vision would be affected. So all these have the same fibers, so any lesion to these three parts, there would be a same result, same visual defect would be seen. Okay, now this was something similar. Okay, this was the similar condition in these three lesions. What is the different condition in these three lesions, and when these three different types of lesion occurs? Let's see it in a diagrammatic differentiation form. So here is a table given in which you can see the difference between the lesion 5th, 6th and 7th. Okay, so in the pupil, what deformities are you going to see? The optic tract abnormality leads to Wernicke's pupil, or also called as Behr's pupil. The lateral genicular body is normal over here. The optic radiation in the seventh one is also normal. So in the sixth, the pupil is normal, and the seventh, the pupil is normal again. But in the fifth type of lesion in the optic tract, you can see a abnormality which is leading to this. Okay. Now in optic tract like lesion, optic atrophy is bilateral. In lateral genicular body lesion, you can see the optic atrophy is bilateral again. And in optic radiation lesion, there is no atrophy. Very important, students. In optic tract like lesion, congruity, there is incognition. The lateral genicular body lesion, there is incognition, but there is cognition in optic radiation lesions. Important. So this was a discussion about the optic lesion, optic tract lesion, lateral genicular body lesion, and the optic radiation lesion. Okay. Now, what are the causes of this fifth, sixth, and seventh? This could be in TB meningitis, syphilitic meningitis, and PCA aneurysm. Okay. Now comes another type of lesion, that is 8th and 9th, and this lesion is in the left optic radiation. Okay, let us discuss this. So the 8th, 9th and the 10th lesion, which 7th, 8th, 9th and the 7th lesion which we are going to study, these are in the optic radiational lesion. Okay, these are optic radiational lesion. What is the difference between them? So the sixth lesion, the eighth lesion, this one, the eighth lesion is in the one part of the optic radiation, the ninth is in the other part, and the both part, if both the parts are affected, then this is the seventh lesion. Let us discuss this in a brief detail. So this is the structure of the brain. You can see the lobes: frontal lobe, parietal lobe, temporal, and the occipital lobe. Here in the bluish dot, you can see the lateral genicular body. Lateral genicular body over here. So the fibers from the lateral genicular body have ultimately has to go to the occipital lobe. Okay, visual lobe. And to go to the occipital lobe, it has two pathways. One goes superiorly to the parietal lobe, and one goes inferiorly to the temporal lobe. One goes superiorly to the parietal lobe, and one goes inferiorly to the temporal lobe. This one, the superior one, okay, so there are going to be two parts of the optic radiation. Okay, this superior one and the inferior one, two parts of the optic radiation. So the superior optic radiation part, which is passing through the parietal lobe superiorly, this is known as the bounce lobe. And the inferior optic radiation, which is passing below or inferiorly to the temporal lobe, it is called as Meyer's lobe. The bounce lobe, here would be the lesion number 9, and at the Meyer's lobe, here would be the lesion number 8. I hope this is clear to you. So first we are going to discuss the lesion number 8, that is also called as the Meyer's loop lesion. And we saw the Meyer's loop lesion in the Meyer's loop lesion, what was affecting? The inferior optic radiations were being affected. Okay, and if the inferior optic radiations are being affected, then the vision affected would be the superior one. Very simple. Let us see. So the left intertemporal, the left infratemporal, and the right infratemporal fibers are being lost. So if these fibers are lost, then which vision would be lost? Totally opposite to this, and that is, if the infratemporal vision is lost of the left side, then fibers are lost, then the vision lost would be superior nasal vision, obviously. And if right infranasal fibers are lost, then the vision lost would be supranasal again. Okay, so this diagram tells you this thing only which we discussed. Very simple. And this condition is known as right-sided contralateral superior homonymous quadrinopathy, or known as pie in the sky. Okay, it is also known as the pie in the sky, p in the sky. Now, not only the vision is affected, the other features that are uncinate fits, seizures and hallucination is also being seen. The next type of lesion comes is Bowman's loop lesion, in which the left superior temporal and the right superior nasal fibers would be lost. If the left superior temporal fibers are lost, then the left inferior nasal, left inferior lesion, let us correct this, left inferior nasal vision would be lost. And if the right superior nasal fibers are lost, then the right inferior temporal vision would be lost. I hope this is clear to you. This diagram tells you everything. If you have any confusion, then just assume a nose over here, and you can clearly see in the left, this is the left inferior nasal would be affected. Okay, and in this, right inferior temporal would be affected. Okay, very easy. So seeing from a mathematical aspect, you can say that lesion number 8 plus lesion number 9 gives us lesion number 7. Okay, 9 plus 8 gives us this 7th lesion. Now we are coming to the lesion number 10, that is lesion in the visual cortex. Lesion in the visual cortex. In this type of lesion, the left temporal and the right nasal fibers are being destroyed, and if the left temporal fibers are destroyed, then the vision affected would be left nasal vision. If the right nasal fibers are being affected, then the vision affected would be right temporal vision. Very easy. Assume a nose over here. The left nasal vision affected, the right temporal vision affected over here. This condition is known as right-sided contralateral homonymous hemianopia, and this is a very rare condition. Okay, so that was all about the lesions. Now in the next session we are going to discuss about the pupil and its lesions in the neuroophthalmology. Okay.